I would like to introduce today's speaker, Dr. Ryan. Dr. Colleen Ryan graduated from Transylvania University and the University of Louisville School of Medicine. She completed a psychiatric residency at the University of Michigan. She retired from the University of Louisville Department of Psychiatry in 2018. She is currently working part-time at Second Chance Center for Addiction Treatment and for Porter Stark Community Mental Health Center. She is board certified in adult psychiatry and addiction medicine. Dr. Ryan, we are very excited to have you here today. I'll hand it over to you.
All right. And I'm happy to be here. I do not have any relevant financial relationships to disclose. Next slide. So we'll go again over the practice gap and supporting resources slides. The treatment of substance use disorder and serious mental illness must occur concurrently to increase chances of success in the treatment of each one. Recognizing the presence of comorbid psychiatric disorders and initiating treatment for them will improve outcome in the treatment of substance use disorder. The learning objectives. By the end of the session, participants will be able to identify the presence of a comorbid psychiatric disorder in a patient with substance use disorder, choose appropriate referrals for care of the psychiatric disorder, apply strategies to support the patient's adherence to both substance use and mental health treatment, and explain the different levels of care in substance use disorder treatment facilities. Next slide, yeah. Expected outcomes. Integration of substance use disorder and mental health treatment will improve patient compliance with treatment, and it will lead to a more successful outcome. So we are going to go over just a few of the slides from the presentation, in case some of you were not here last time, and then we'll have a discussion. So we talked a little bit about are people with co-occurring disorders getting the appropriate treatment? And what I found when I did some research for this presentation was that 47.8% of adults with serious mental illness, which is SMI, used illicit drugs in the past year. Now, SAMHSA defined this in their study. This is from the NASDA, NSDUH, the National Survey of Drug Use in Households. They define SMI as any mental illness in the DSM-5 that seriously interferes with treatment. So it isn't necessarily just, schizophrenia, bipolar disorder. AMI is any mental illness, so that is anything that's in the DSM-5, much broader category. So 47.8% of adults with SMI used illicit drugs in the last year. 39.8% of adults with AMI used illicit drugs in the past year. They are including cannabis with this. 17% of adults with no mental illness used drugs in the past year. So you can see the big difference. People who don't have a mental illness are not using as many drugs. Adults with serious mental illness had a higher percentage of illicit opioid use, marijuana use, binge alcohol use, and tobacco product use than those with any mental illness or no mental illness. So the highest category of users are the people with the serious mental illness. The difference between the estimate of substance use for those with mental illness versus those without is statistically significant. So are they getting services? And again, this is from the 2020 NSDUH. Among the 17 million adults 18 and older in 2020 with a co-occurring substance use disorder and any mental illness in the past year, 50% basically received either substance use treatment or mental health services. Half of them received neither service. Again, this is any mental illness. Nearly half of adults with a co-occurring substance use disorder and any mental illness did not receive treatment. 42.3% received only, of those who did receive treatment, 42.3% got mental health treatment, 2.5% received only substance use treatment, and 5.7% received both mental health and substance use treatment. So you can see that there are a substantial number of people who either aren't getting treatment or They're getting one or the other and probably not both concurrently. So this is from the American Academy of Addiction Psychiatry policy statement on co-occurring psychiatric and substance use disorders. This is what they are recommending, the goal. In both psychiatric and addiction treatment programs, the presence of co-occurring disorders should be expected, not the exception. So again, it's going to be there. Don't be surprised. These patients have higher medical comorbidities, and their clinical course is associated with higher costs and poorer outcomes. These patients are best served in settings where treatment for both disorders is available and sufficient resources are available. One of the things they emphasize is integration of treatment. Psychiatric and substance use disorders are both examples of primary mental illnesses, and the recommended treatment approach is integrated dual primary treatment that utilizes a disease and recovery model in a single setting. Individuals should have a primary treatment relationship with a physician or nurse practitioner or nurse or someone, even, or, a social worker that coordinates ongoing treatment interventions for each disorder. Each disorder should have specific and individualized treatment, but everybody needs to know what the other person is doing, which is key. Some common comorbidities with opioid use disorder. From a psychiatric standpoint, major depressive disorder is a big one. Probably the most common, and I think as we talked about last week, especially early in recovery, it's not always pleasant when people first achieve sobriety and they have to deal with a lot of the chaos in their lives. So there's a lot of depression, especially early in recovery. Also bipolar disorder, PTSD, generalized anxiety disorder, panic disorder, social anxiety disorder, and ADHD. I think if you remember from last week, there was a slide that said 1 in 6 of people who present for substance use treatment have ADHD. From a medical standpoint, hepatitis C, of course, is a big one for people who've used needles. HIV, liver disease, cardiac issues, osteoporosis, that's more of a long-term issue. Infertility, hyperprolactinemia, and a lot of respiratory issues, bronchospasm, worsening of asthma, smoking, using, cannabis. And those need to be screened for. So these people really need access to primary care. ADHD and substance use disorders, I emphasize this because I was seeing so much of it where I work at Second Chance. This was from a study, I think they were looking at commercial healthcare claims. And from 2005 to 2014, they looked at commercial healthcare claims from about 3 million adult and adolescent ADHD patients, 47% female. They compared the risk of substance-related events during times when the patient was taking medicine versus times when the patient wasn't taking medicine. Part of the issue here is, there is always this fear that when you're exposing people to use of stimulants, and often people with ADHD end up on a controlled substance, Adderall, Ritalin, Focalin, whatever, you worry that they're going to abuse it or it's going to lead them to abuse other drugs. So that was part of the purpose of this study. What they found is that male patients had 35% lower odds of concurrent substance-related events when they're receiving medicine. And female patients had 31% lower odds of concurrent substance-related events when they were receiving medicine. So they didn't have as many substance-related problems when they were receiving medication. Male patients had 19% lower odds of substance-related events, even 2 years after medication periods, and female patients had a 14% lower odds of substance-related events 2 years after medication periods. So this is basically, suggesting that people actually do better when they're on their stimulant medicine, and they're not as likely to engage in substance use. I think we need a lot more research on this, but this is what it looks like. Again, it can be hard to tell sometimes whether something is substance induced or a primary mental health disorder, or whether maybe somebody had a vulnerability to a primary mental health disorder and then the substance use exacerbated it. So particularly with bipolar disorder and substance abuse, usually you try to get a 30-day window when they're not using to try to discern what's related to the substance and what's not. Of course, especially when people are using stimulants like methamphetamines, they can look very manic. It can be difficult to tell. So you try for a 30-day window. That may be tough because a lot of people, when they're early in recovery, they don't necessarily just stop using all at once. So you may still get some use over that 30 days. It may be hard to get a 30-day window with absolutely no substance use. So that makes it a little bit difficult. If the patient has manic or psychotic symptoms, and this is my approach, if they're very manic or psychotic and they're out of control, you can't wait 30 days. You may have to hospitalize them, or you may have to treat with an antipsychotic. I don't think it's quite as effective when they have, drugs on board and you're trying to use an antipsychotic, but you do have to deal with their symptoms. If you're using a mood disorders questionnaire, a lot of people use this as a screener for bipolar disorder. It's the mood disorders questionnaire. You've got to ask them to rate it on a period of sobriety, and that may be hard because they may not really remember, what they were like during a period of sobriety, or even during a period of sobriety, if it was like 1 or 2 months, they probably still had some, influence from the substances they were using. So I use the mood disorders questionnaire sometimes, but I think you have to sort of put it in perspective. A lot of patients that I see, especially early in recovery, they talk about a lot of mood lability, and a lot of them have been diagnosed as bipolar. But to me, mood lability is kind of something you see a lot early in recovery. People their neurotransmitters are still kind of out of whack, even for 6 months to a year. They don't have good coping skills. They're dealing with a lot of stress sometimes, trying to find a job, trying to get their lives stabilized. So I think, I don't diagnose mood lability as bipolar disorder. So I think sometimes bipolar might be a little bit overdiagnosed in this population. And treating anxiety disorders, there's especially a correlation between social anxiety disorder and alcohol use disorder, which makes sense if you think about it, because alcohol is a disinhibitor. And so people with social anxiety disorder feel a little more, social and less inhibited when they use alcohol. A lot of recovering patients have anxiety. I see it all the time. And I'm always asking myself, these questions like, is it the influence of the substance that they've used that is still sort of, affecting their neurotransmitters? Is it that they're intolerant of feelings? They're just not used to feeling feelings? Is it that their feelings are more intense because they're coming off substance use? They have a lot going on in their lives. And do you treat, and what do you treat them with? In some ways, I think we like to say with anxiety, well, it's something you need to learn coping skills. Everybody has anxiety, but with a lot of these patients, their anxiety it's interfering with their lives. The ones that I see, I'm talking about that kind of anxiety where they're not going out of the house. They can't go to meetings because they're so anxious. A lot, they may not have access to intensive therapy. So, I think that regardless of the cause, they need to be treated. And sometimes they need medication. And you have to look for underlying conditions. I've seen people who present with anxiety, but what they really have is maybe ADD, or they may have PTSD. That's a big one, a lot of PTSD, and they have anxiety related to the underlying condition. Some of the conclusions, treating substance use disorder, including opioid use disorder and comorbidities, whether medical or psychiatric, is treating the whole person. There are many associations between substance use disorder and co-occurring disorders. Sometimes causation is not clear, and you may never really know exactly what came first. Each patient is different. Make the treatment fit the patient rather than making the patient fit the treatment. We talked a lot about that last time, that we've had a tendency, I think, especially in addiction treatment, to have these rules about, who meets our criteria for a program, or who, doesn't meet criteria. And, we need to sort of get away from that and think that people are individuals. And if somebody doesn't do well with one treatment, it may not be the patient. It may not be that the patient's motivated. It may be that the treatment wasn't right for the patient, or it needs to be modified a little bit. And sometimes the most difficult patients can be your greatest success. And I think, one of the reasons I really enjoy working with addiction patients is I have seen so much progress. And sometimes in the field of medicine, you don't always see that a lot. I know that people who work in ERs probably see the other side of addiction, and I can understand that. But in an outpatient setting, I have seen people go from, homeless to having their own apartments, working a job, being independent with income. I've just seen a lot of success. Okay, so now we can start to talk about questions, and we came up with some just to sort of start the discussion. And I hope that other people will contribute to this as well. So we have a 29-year-old male with a history of heroin use and PTSD presents to a facility for treatment. His last use was 3 days ago and is currently experiencing only mild withdrawal. He's told that because he has not used today and his withdrawal score is low, that his insurance won't pay for detox. He is also told that the recommendation is a minimum of 60-day treatment, but insurance will only pay for 14 days. How would you help the client navigate these barriers? So, unfortunately, we're always dealing with insurance, determining care, and that is a problem. I guess what I would say, and I'm sure that some of you out there have had these experiences, so I'm interested to see what you think. I think, first of all, you have to be sure that you're clear about what this person needs. Not everybody needs an inpatient detox treatment. So this is a person who is using heroin and is in mild withdrawal. And I think, when you talk with insurance companies, you have to be sure that you're asking for the right thing. ASAM does have the level of care tool that you can use. I don't know if any of you use that, but it's fairly long questionnaire that you can go through with a patient and determine what it is they really need. Do they really need inpatient detox? Do they need inpatient detox, like in a hospital? Do they need detox maybe in a freestanding place where they do detox, but it's not necessarily a hospital? What do they need exactly? A lot of times, if you use the ASAM level of care tool and you can talk to an insurance company using that information and saying, this is what the level of care is coming out to be on this tool, a lot of times they will listen to that. Sometimes. Usually detox is not 14 days anyway. Normally detox is, 5 to 7 days max. If they really need an inpatient detox. So, and detox is just the beginning of treatment. People, all the studies have shown people cannot just go to detox and then think that they're okay. They have to be in an outpatient treatment. I work in the outpatient setting. Our clinic is an MAT clinic. We treat addiction with medication. We have mostly opioid use disorder. So we would take somebody like this in our outpatient clinic who is in withdrawal, but it's mild withdrawal. They can be started on medication, at that point. They don't have to go to an inpatient detox treatment. As a matter of fact, they need to be in withdrawal to start Suboxone if that's what they're willing to do. I've had pretty good success. I mean, I'm not seeing insurances refuse outpatient because outpatient is cheaper. They're pretty good these days about paying for Suboxone or Vivitrol or, naloxone, whatever, naltrexone, whatever you want to start the patient on. There is some improvement there. So generally, if you can get somebody, especially a person like this, who's using opioids into an MAT clinic that can do an evaluation and start dealing with the withdrawal on an outpatient basis. The PTSD, obviously you'd like to find a clinic that has, is dual diagnosis capable, meaning that they have someone there who's a psychiatrist or psychiatric nurse practitioner. If not, then hopefully that clinic will link the patient with someone who is. So that's my thought about this. I don't know if anybody else has any thoughts about it.
I agree. I think it sounds like kind of almost like a standard patient for outpatient behavioral health treatment. So I wouldn't be thinking that he needed inpatient just from this history that we have here, at least at this point.
Right.
But I would really be thinking more maintenance rather than, a taper too.
Yes, I think the key when you talk to insurance companies is you've got to speak their language. You have to know what you've got to say to get what you need. A lot of clinics do have people who specialize in that, who can call insurance companies, try to get more days. But you sort of have to know the language. Okay, the 3 top advocacy efforts needed to address barriers. For example, insurance limitations, expected medication for opioid use disorder for all mental health settings, case management reimbursement. So as I thought about this, and again, I think other people will have other ideas. I find that really the bottom line a lot of times is still stigma. I think there's still a lot of stigma that keeps people from, getting into the treatment that they need. And it influences these things. It still influences insurance companies. It still influences legislators. And, I just read, I think it's here in Louisville, maybe, where they want to put somebody wants to, or no, maybe it was Georgetown or Elizabethtown. They wanted to put residential treatment facility for women in, they bought a house, they bought some property, they want to put a treatment facility there. Maybe it wasn't for women, I think it was for men. And of course, the community is objecting. They don't want these people in their neighborhood. They don't want them walking around. They don't want them around children. Lots of assumptions, lots of stigma. Not in my backyard. So I really think that is I see this a lot in judicial circles, like judges. I've had patients who come in and tell me, this judge doesn't like that I'm on Suboxone. The judge tells me that, in order to get custody of my kid, I need to get off Suboxone. That drives me nuts. So there is just a lot of stigma also from physicians. I have patients who go to their primary care doctor and they feel they're treated differently. And I think they're right about that a lot of times. I've had patients tell me that doctors tell them, that Suboxone is just a substitute. You need to get off that. So I think stigma is actually underlying some of the issues that we have getting access. The other thing, is access. Understanding that, people need to be able to get in for treatment. If you're talking about having these multidisciplinary clinics, which is sort of what we're recommending, where you have, primary care, you have OBGYN, you have psychiatry, GI specialties, because you see a lot of hepatitis C with this patient population. But those are not going to be in every community. You're going to have those in a place where you have a concentration of doctors, but people have to get there. And I know I looked at a study recently that had to do with Kentucky, and it talked about how many counties really, they don't have bus systems, they don't have taxis, they don't have Ubers. In Fayette County, we're lucky that, and I guess this is from a grant, we can pay for an Uber in Fayette County for people to get into treatment, but access is the issue. So if people can't get into treatment, you have to get it to them. And that means maybe some kind of mobile treatment. It means telemed maybe. So, and that is where you kind of have to advocate with legislators, because in Kentucky, Suboxone is very regulated. Other states are a little more liberal about it, but in Kentucky, there's still a lot of kind of bias on the part of legislators against it, still some misunderstanding. They worry about it being diverted. So there's a lot, you're supposed to get urine toxes regularly. You're supposed to do observed urines to make sure they're not bringing in fake urine. You can't really do that with telemed very easily. So even if you're doing telemed, if you're going to follow those rules, you've got to be able to see them in person periodically or relax those rules somehow. So access is, another issue. Stigma, access, and I think a lot of it does take working with legislators. So those are my thoughts. Case management, yes. Reimbursing what needs to be reimbursed. Case management it's a big issue. And that's where, in the clinic that I work in, we get a lot of help with trying to work out housing and transportation with case management. I think it's not always reimbursed individually. I'm not sure how that works in a lot of clinics, but it's definitely not reimbursed in the way that it should be. That's advocating with legislators who have, are going to push Medicaid to do that, or other insurances. Mental health parity was actually passed federally probably 20 years ago. It's never been enforced. If we enforced it, we would solve a lot of these problems, I think. How do you think peer support specialists and care navigators, case managers can address the specific needs of clients who have a serious mental illness and are seeking treatment or in recovery? How can peers and navigators best help connect to additional mental health resources, especially if the clinic they're working in does not provide mental health services? I think that you've got to know what's available in your area. And that's important. And I know I really rely on our case managers for that, because I live in Louisville, but I'm working in Lexington. I don't know Lexington. And I'm sure that, people don't always know what's out there. So I think you just have to know what's out there and form relationships. I still believe in our field that having a relationship with somebody who's in a program where you want to get a patient in, like talking to them, getting to know them, so that you can call up and say, hey, I've got so-and-so, it goes a long way. So I think that knowing what's out there and having a relationship, can make a difference. I would be interested, I know a lot of you who are on today are care navigators. And so, we have some case managers at Second Chance, but I'm interested to hear from the care navigators about how you do this and, what you do exactly. If any of you could address that for me.
So I'm Emily. I'm one of the care navigators in Madison County. And kind of our role in a lot of these clinics and agencies around Kentucky are helping folks reducing barriers to staying in treatment or connecting them to treatment. And as we all know, a lot of that looks like kind of helping them coordinate care with different physical health providers, mental health providers, but also really being able to work in the community with them, to making sure like having like that extra layer of accountability and support for them.
Okay. So
Emily,
how do you get reimbursed? I'm curious. Do they bill for your services?
No, Colleen, this is the care navigators and the peer support specialists are all funded by the Healing Community Study.
Okay.
So it's like two new workforces that we've created. They work really independently of the agencies. So it's been really interesting because they're first and foremost person that they're there to serve is the patient or the client.
Mm-hmm.
And so, there have been some times where there's some rigid rules at a particular clinic and the person's getting kicked out, but they don't really want to be kicked out, right? Like they really still want to be on medication treatment. And so luckily, if they're working with a care navigator there, that care navigator can, help them get connected with a new provider or can try and help intervene and say, look, is this really what you want to be doing? And kind of try and have a constructive conversation. Okay. So I don't know if there's like a care navigator out there that can maybe give some examples of some really wonderful successes that they've had with a patient that was maybe close to dropping out of treatment or helping them get in, just to give a little bit more of a flavor of what you do.
Tanya, I'm going to call on you about your gentleman last week who you had such a success on. Do you want me to? You want to share it or do you want me to?
I can do it. It's like
okay.
We had a client that was basically was homeless, but had not been using. But so we have an assistant in emergency housing fund that we were able to place him into a hotel for about a week. And at that time, within a week, that guy had obtained employment, and then and he only stayed in the hotel for about 4 days, I believe, and was already living into sober living. So that was pretty amazing. So quite a success in a short period of time, just by being able to afford him a nice warm place to stay and place to be clean for a day. So he could go to an interview and be, and be employed. So that was pretty neat.
Was that someone who was already in treatment, or was he trying to link to treatment?
Yeah, he had already been, I'm in retention side of it. So yeah, he was already in treatment. I think he'd been there for, I want to say 6 months, but always kind of running that risk of not coming to treatment because of being homeless and so forth. So it was kind of neat to see that success in a very short period of time due to the Heal program. So
how do patients get linked with you as a care navigator?
So we have linkage. We have both linkage and retention navigators. Our linkage navigators are working in the criminal justice setting and in other similar settings. So they are working with clients who have an opioid use disorder, but are not currently in treatment. So they're linking them to the treatment. And so our retention navigators, they get their referrals from the clinics. They are placed physically in the sites, and that's how they get their referrals.
Okay. I mean, I just think we need so many more of you and it needs to continue beyond the grants. It's always my concern about grants, is it going to continue? I mean, I
wanted to add to that because I was kind of thinking about the first question that we were talking about in terms of stigma, and those who have SMI diagnoses, and how we can kind of break that barrier. I think one of the biggest barriers in terms of stigma that the navigators have found is one of them has to do with naloxone distribution. which this was new to me. A lot of clients say that they don't want to carry naloxone because it's, their significant other or their friends or family are going to suspect that they are using. So one of the things that we've really tried to do as navigators is say, hey, this isn't just for you. This is a community thing that we're trying to fix.
Right.
You may be out in the community and you may witness someone having an overdose. So, carry this for that person, not necessarily just for you, because you've been in recovery and remission for 2 years. That's wonderful, but we still have this community issue that we're trying to fix.
Right.
And so I think that kind of piece goes into the whole sustainability topic too, of how can we keep this going when we're no longer here.
Yes. I mean, I know people who keep it in their glove compartment just to have it, in case they run into somebody and they need it. And I think that if they're getting negative feedback from family or physicians or somebody, I just think it's going to compromise their success unless you somehow reach out and deal with those people. So.
Yeah, I have it in my purse.
Mm-hmm.
And we've like had a lot of events where, like even at UK, separate from the study, where it's been given out, for free to students, medical students. We've gotten reports back from, one medical student that just on his way home saw someone on the side of the road end up being overdosing and just saved someone's life because he had the Narcan. So it seems like almost like something that we need to have like the whole community have, regardless of whether or not there's someone in their family or they themselves are affected, just to kind of just to destigmatize it and say, look, this is a life-saving, who doesn't want to save a life, right?
Yeah.
And that there's so many overdoses that happen in places like libraries or gas stations or grocery shops where we all go, that there's a good reason to have everyone kind of have it. Yeah, we're excited to have the navigation program. So we're collecting data. So all of our navigators, Colleen, are collecting data on when they enroll someone and the outcomes and the transport and all the barriers that they're trying to bust, with the idea that this will become something that is sustainable, that will have some data and research from it, and that hopefully one of these days the Federal Parity Act will get actually implemented.
Right.
This is exactly, I think, what we need.
I think was there something in chat? Somebody asked something.
So it's from Michelle Cunningham, and she just asked, what programs are available for youth in rural areas for substance use treatment placements?
And I have to say that I probably don't know that. I would have to rely on somebody else or look it up.
So I was gonna say, maybe to the larger group, if anyone's aware of anything.
Does
Sorry, can you repeat?
Charter Ridge take adolescents and young people? I know in Louisville, our Tenbrook, I think, has a child and adolescent unit and some child programs, but I really don't know about other places, honestly.
You're pretty much Ridge and in Lexington, and in Bowling Green, there is one, I'm trying to think of the name of it. And then Tenbrook, and I'm not sure, is Lincoln Trail still available in the Louisville area as well?
I know here, for adults. I don't know about adolescents and children, but they used to.
Years ago they did take adolescents.
Mm-hmm.
But the rural areas don't have a lot of outpatient programs that I'm aware of.
Right.
That's what we're running into. I'm a local resource coordinator on the Salt River Trail REAC, and one of their main focus right now is the youth substance resources, that they don't have any programs out in the outlying counties to get kiddos connected to, or programs or even meetings for that matter, specifically geared towards the youth. And a lot of these kiddos are being removed from the homes because the families, like either a guardian or parent or, whoever's the caregiver that's taking care of the kiddos, They're also suffering from some types of substance abuse, and they don't have any placement to take care of the kiddos while they go and get treatment. So that's kind of like this ongoing cycle. So if you guys have resources that I can share with them to help get people connected to, that would be great, because I know that's one of the survey responses that we just got back, was that there wasn't any access for people to get, not only for the parents, but in these rural counties, but also for the kiddos that are also dealing with substance misuse.
That's hard. Have you been able to use any sort of telemed services to link with, an adolescent treatment provider, adolescent psychiatrist?
Some, yes, but some of the programs are actually expiring, I think, on the 14th of April. So they're trying to request extensions to be able to provide that service. But once they go back into in person, that resource is going to be very limited.
Yeah, I think your next Kentucky Open session is on adolescents, right? Yeah.
That's correct. That will be on March 17th and the Q&A session on March 31st. So there may be some helpful information in that session.
Okay. So we probably could go to the next question. Is there data around individuals who receive primary care for mental health and substance use disorders within primary care? What are the top recommendations for those in rural communities who don't have access to specialized care, or those who cannot be seen by specialists due to lack of available treatment spots? I really could not find solid data about this. Definitely there is a move to include mental health care in primary care clinics. It may not always be a psychiatrist. It might be a therapist. It might be, a psychiatric nurse practitioner. So there is a move to do that. As far as, what that's like in Kentucky, how many primary care practices are doing that, I really don't know. The other issue is you've got to find, I've gotten calls from people who want a psychiatrist within their practice, or a psychiatric nurse practitioner, and haven't been able to find one. So you've got to find the person. You've got to have people available who could do that. But even, having a therapist can be very helpful. A lot of people benefit from a short-term therapy. But I don't know that, how often that's really happening, or that person can facilitate getting a patient in to see somebody who can provide medication. As far as recommendations for those in rural communities, telemed should be able to help with that. Again, you've got to have telemed available. You've got to have care providers who are willing to do it. That way you should be able to link into some of these multidisciplinary clinics. I think that, one of the issues with Suboxone, for example, during COVID, we were able to do a lot more telemed for people on Suboxone. The rules about it were relaxed. And so, we were able to do a lot more. Now that COVID is sort of beginning to die down, we're kind of going back to some of the rules we had, which make it a little bit harder to do telemed with those people, because we have, Kentucky Board of Medical Licensure they're pretty strict about Suboxone in this state. They're worried about diversion. So, you're supposed to have so many urine toxes per 6 months. You're supposed to have certain things done. You're supposed to do some pill counts. Some of those things have to be done in person. People have tried creative ways to do it via telemed or indirectly, but it doesn't always work. So unless we relax our rules a little bit, it's going to be harder for people with opioid use disorder to just do telemed. And some people think that it shouldn't just be telemed. There's a little bit of a controversy about quality of care with opioid use disorder if you're only doing telemed. But telemed does make it more available. The lack of available treatment spots, that's a hard one. Having more providers, that's hard. I think you have to look for treatment. You have to look for maybe, some practices out of your area that may be able to take patients. You got to find somebody who takes Medicaid, because a lot of our patients are on Medicaid. Medicare is an issue. I know our clinic, Second Chance, doesn't take Medicare right now. Finding somebody, in the addiction community takes Medicare can be an issue. And I know a lot of, for example, in Louisville, a lot of psychiatrists don't take insurance. So again, that's access. I'm not sure I have a good solution for that one, but telemed should be able to help. Have you had trouble getting people in because of lack of available treatment spots? Or is it more transportation and that kind of thing? Any thoughts on that?
Michelle Cunningham actually brought up a pretty good point in the chat about even in like really rural areas, access to internet for telehealth can also be a barrier.
Right. I think we need to have a better transportation system for one thing, more buses available. Yes, I'm saying limited phone access. I forget, yes, there are people out there who don't have a phone. So we're coming up with a lot of problems and not a lot of solutions, but I do think that a much better transportation system. I know Medicaid will provide bus service, at least in some places. Some of our patients can get a bus from surrounding communities into their appointment. I have encountered some people, though, you can't use the Medicaid bus thing if you have a car, but if your car is not working and not functioning, it still counts as a car. So you still can't use the Medicaid transportation. And somebody was saying, yes, I think you have to buy a ticket, right? Even with Medicaid. So.
You don't have to buy a ticket for the Medicaid transportation, but you do have to arrange it 3 business days before.
Okay.
And even if someone else has a vehicle at the home where you're living, that eliminates you from being eligible as well. So there's a lot of barriers. And I've also heard that if someone has a wheelchair, that there's not always a way to accommodate for disabilities, physical disabilities.
Oxygen tanks was another one I had. I have a fellow that needs transportation and he's got Medicaid and everything, but he has to carry along 2 pretty good size oxygen tanks and they won't take him on the bus. So it's like,
Yeah. I mean, I've had a lot of people say they're late picking them up. They don't pick them up. And, the 3-day thing seems reasonable for a lot of our patients who aren't very organized. Actually, that's a problem. I have one patient who doesn't have a phone, so he can't really call to make his appointment. Transportation, just free transportation. And I think these are things that, we need to bring up with legislators and the people who have influence on Medicaid. Realistically, I think people it's nice to have things in your community, but realistically, people are going to need to come in person sometimes for appointments, and you can't do that if you don't have transportation. So it's basically key.
A few more barriers mentioned in the chat is the bus tickets. If you do need those, you need to have an address for the tickets to be mailed to, so that can be a barrier. And then Charla mentioned that there are issues with using Medicaid transportation for certain MOUD treatments.
Really?
So that as well.
Okay, I'm curious about that one. Can that person say more, maybe?
So I believe the regulation is the Medicaid transportation can't be used for methadone appointments.
Oh, okay. I didn't know that.
Yeah, I think that's right, because that was a sticking point in order to get Medicaid to pay for methadone treatment. They weren't going to be able to afford for daily visits to pay for the transportation and for the treatment. So the requirement to transport Medicaid patients was removed from the methadone treatment. So Medicaid pays for methadone treatment now, but it was only able to do so if it didn't have to also pay for the transportation that's so
right.
frequent.
So I think, people who are not in the medical field, legislators tend to look at the cost of certain things up front, and I understand that, but they don't always think about the cost savings down the line if you're providing patients with the care they need, and therefore they're not inappropriately using the medical system, for other things because they're stable. We don't really look at the cost savings down the line. How is treatment of substance-induced mental illness different than a primary mental illness? How does recommended treatment differ based on these differences? Well, first of all, if you have somebody that you feel has a substance-induced mental illness, if you can, you try to, at least, I try to hold off on treatment if I can until I feel like they've had a little bit of a period of sobriety, so that I can tell, if they've had the 30-day window with very little use, if none, and they still have symptoms, then I would consider it more of a primary mental illness. But that terminology, you can't really think concretely about that, because if they still have symptoms after 30 days, you call it a primary mental illness. It could have been that they had a vulnerability that was exacerbated by their substance use, but at that point, I think, you need to treat it. 30 days is pretty minimum, really. Some things hang around longer. I really think that sometimes for people to really, for the body to adjust to not being on drugs, it takes way longer than 30 days. But you can kind of, if this is purely substance induced, as time goes on, it should get better. And if you can afford to, and they're not really, extremely disabled by their symptoms, you can get them into maybe some therapy counseling and try to just watch. If the symptoms are not going away, then you go ahead and treat it as a primary mental illness. You may never know whether it's possible that if they never used substances, it wouldn't have, been there, but you really have to go ahead and treat it. My experience is that most people, do respond pretty much the way they would if they hadn't used substances, if you've kind of got that little window of sobriety. I do think that particularly with methamphetamine, if you're trying to treat somebody who has psychotic features and they're still using some meth, I treat with antipsychotics. I don't think they work quite as well, but if they're having really prominent psychotic symptoms, you've got to try and treat it. I think the issue for me is, how much is the symptom disabling the person? And if it's really disabling the person, you may have to try and treat it, even if they're still occasionally using some substances. Because it may be actually, if they're very disabled, maybe that's contributing to relapsing. So I don't get into a real argument with myself about whether it's primary, secondary, or whatever. I kind of look at how much it's, have they at least reduced their use of substances, and how much is it disabling the patient? Yeah, this was a slide from last time that I included here. These are some of the things that I do look at. Did the person have any symptoms that preceded the onset of substance use? Of course, that's a big clue. Some people started using substances very early, so, it makes it hard to tell. But if they had a window of time before they were using and they had some depressive symptoms, bipolar symptoms, that makes it a lot clearer. Did the symptoms persist for a substantial period of time, about 1 month after cessation? Or withdrawal, cessation of withdrawal or severe intoxication? Is there other evidence suggestive of an independent non-substance induced disorder, such as episodes of the disorder occurring in childhood or in other periods of non-substance use? Again, it can be hard to determine whether the person's truly been substance-free for a month. If they substantially decrease their use, then I think you can kind of get some idea of what's going on. And it's hard to really get an accurate history. Family history can be helpful, if you feel like it's valid. if there was a great deal of substance use in the family, then you never really know whether that bipolar diagnosis is accurate or whether, you know, the person was really using when they got the diagnosis. But family history can be helpful, especially when it comes to maybe psychotic disorders like schizophrenia or schizoaffective disorder. That can be helpful. Okay, if a person is in active use and experiencing acute mental illness that may have similar symptoms, how can a non-clinician identify the potential need for specialized care of a dual diagnosis in order to make the appropriate linkage? Well, I think that even if they're in active use, if they're having acute symptoms like they're suicidal or they're psychotic, or they're, you know, extremely depressed, then they need specialized care at that point. If you can get them into a clinic where somebody can do an evaluation and determine if they need inpatient, you know, we would do that in our clinic. If you referred somebody to our clinic, we do an assessment and determine if they needed a higher level of care than what we could provide. And I think that's the way most clinics would do it. So, you know, try to get them into a mental health clinician who can determine what level of care they need. But I mean, I wouldn't wait around. If they have symptoms, even if they're using, they need referral.
I would say that if you have the client that is unable to like maintain themselves with an MOUD treatment center or any other treatment center due to, you know, psychiatric symptoms, that would be a way to say, ooh, we might need to take care of this together at the same time, same place, right? That's how I would kind of see that as an issue. If they were not able to maintain their appointments, sit still in a group, you know, that's where I would say that they would probably need to be referred somewhere for that kind of treatment.
Mm-hmm. Yeah, I agree. And I think if you're referring out and you don't have that in your own clinic, then it is, again, communication between providers is important. And maybe you all help with that too, because that can be a real issue with people who are going to 3 different places for treatment, is making sure everybody's on the same page and knows what the other person is doing. Sometimes people need inpatient treatment. They may need an inpatient, most inpatient psych units. Well, there might be a few, but you know, in the past, sometimes inpatient psych units didn't want to take people who were actively using because they'd say it was substance induced. I think that is a little better. Most inpatient psychiatric units would take somebody with acute symptoms, you know, try to sort of rule out or rule in what's going on. So if somebody is actively dangerous to themselves, they should be able to get into an inpatient unit, even if they're using. Okay. Any other thoughts about that one?
We can just open it up now. If you all have any other questions or discussion that you would like to have, this would be a great time for you to share your thoughts.
I've got an interest, I don't know, it's kind of on the same topic as far as like referring people out to resources or to treatments and those kind of things. One of the barriers that I've just started to see with some of our clients that I've dealt with is, I say, well, even just to go to the Salvation Army thrift store or whatever, they have to they have to set up an appointment, meet it with a case manager, go through an assessment, have so many contacts, that maybe not with the Salvation Army, but so they may have 4 case managers across this whole spectrum of treatment, and they have to keep repeating this thing over and over again.
Yeah.
You know, because I think there was a referral here once, and the client was like, oh, just is somebody else to call me or someone else I have to talk to, you know?
Mm-hmm.
So I think that's interesting. I had never really thought about that, but these guys tell their story 1,000,000 times just so that they can get a service, right? And I think that's interesting. I was like, I had never thought of that as a barrier to treatment, is treatment, you know? And I know we have to do the assessments and we have to do the contacts to get the billing and all that kind of stuff. But I just found that really interesting. So I was like, that would be annoying if you had 5 people you had to talk to in a week.
I think that's very true. I mean, and I think that's an example of where we sort of, you know, make patients jump through hoops rather than being more open to, you know, bringing the patient in, doing what you have to do to get them in rather than making them jump through hoops. I think that's very true. Yeah.
I just thought that was interesting. 'Cause, you know, I had a client called just the other day, and I had not yet completed his intake assessment. And he was like, "Can you help me get transportation?" And I was like, you know, in my head, I'm going, "Oh, but I haven't done that paperwork." And I was like, "Yes." You know, it's like, it's just like, you know, just call them. I need to call them today, get the intake done. But it was like, yeah, I can help you do that. You know, it's like, that was kind of interesting.
Yeah. I know a lot of times when I listen to patients come in and they tell me they're, you know, they've called the food stamp line 5 times with no answer. You know, they can't get their heat turned on. It's like, I think if I had to deal with those, they're always having to deal with systems, you know, and I think that most of us just fortunately don't have to do that most of the time, but I feel like, you know, these patients are just always fighting with systems.
I'll share from this chat. Michelle Cunningham shared that the barriers that are the biggest thing I see and hear from people will not follow through because of all of the hoops or barriers or getting access to something. Even having their state ID or their medical card on them is a barrier, or the Social Security office or their Section 8 office where no one is answering them.
Yeah, I know. And I hear that a lot too. I don't know if it's because these offices are not staffed well or they're minimally staffed, but yes.
Lisa posed a question, are you seeing any increase in success with mental health treatment for those clients that are being treated for opioid use disorder with Sublocade?
I don't know that Sublocade has necessarily changed the success with mental health treatment. I mean, I think that just getting people into MAT and trying to, you know, stabilize their addiction to some extent increases the chances for them to do well in mental health treatment. I don't know that I see a specific correlation with Sublocade. I do know that a lot of the patients, I don't do it myself, but we have a nurse practitioner at the clinic who prescribes Sublocade, and people have been really happy with it for the most part. I don't know how other people use it. We use it more in people who are kind of stable. So they're really not early in treatment. They're pretty stable. They're pretty stable on their dose. And they don't need to come in, you know, with Sublocade, it's like a monthly injection. So you don't come in quite as frequently, but some people need to come in more frequently just for support. So we use it more with people who are kind of on the stable end of things. I don't see that it necessarily changes success in mental health treatment one way or the other, though. I mean, I think that trying to do both treatments together, or at least you get them into one or the other and then link with the other treatment, whichever they need, is the thing that makes most sense.